the second lecture about the pancreas. Just to remind you about the previous information about صوتي واضح مو طلاب عيني صوتي واضح.
نعم دكتور واضح.
Okay. About the complications of acute pancreatitis, you know there are local complications like acute fluid collection, sterile pancreatic necrosis, infected pancreatic يعني necrosis, pancreatic abscess, pseudocyst, pancreatic ascites, and pleural effusion. These are all local. There are also يعني systemic complications like cardiovascular, shock, arrhythmia, pulmonary, ARDS, renal failure, hematological, DIC, portal splenic vein thrombosis, metabolic, like hypocalcemia, hyperglycemia, and hyperlipidemia, gastrointestinal ileus, neurological. There are visual disturbance, confusion, irritability, encephalopathy, and other miscellaneous complications like subacute fat necrosis and arthralgia. So, pancreatitis is a serious disease and may be very complicated and maybe life-threatening situation. And as we said about the medical treatment of a chronic pancreatitis, we should treat the addiction, help the patient to stop alcohol consumption and smoking, also alleviate abdominal pain, and the nutritional pharmacological measures with treatment of diabetes. Now we discuss the carcinoma of the pancreas. طبعا carcinoma of the pancreas, you know there are predisposing factors, which are number one, demographic factors like the age. It is the peak incidence in the 7th or 8th decade of life, more common in male and black ethnic. Environmental, cigarette smoking is a predisposing factor. Family history is also important. Diabetes mellitus. So these are the predisposing factors. Regarding the pathology of pancreatic cancer, more than 85% of pancreatic cancers are ductal adenocarcinoma. More than 85 are ductal adenocarcinoma. Endocrine tumors of the pancreas are rare. Ductal adenoma arise most commonly in the head of the pancreas. And once it is present in the head, it may causing a pressure on the duodenum, on the lower end of the common bile duct, may causing obstructive jaundice, painless jaundice, and may have other symptoms. They are solid squamous tumor characterized by neoplastic tubular glands within the markedly desmoplastic fibrous stroma. That's why it is squamous. تعرفون شنو معنات سكرس طلاب؟ طلاب تسمعوني عيني تسمعوني؟
نعم دكتور السؤال.
تعرفون شنو معنات سكرس عيني؟ معنات سكرس تعرفون شنو؟ سكرس يعني من تكون التيومر يعني فايبرس وسوليد احنا نسميه سكرس تيومر، يكون فايبرس، يكون gritty on cutting. Once we cut it by knife, it is gritty due to severe fibrosis. So fibrosis but fibrosis is also a characteristic feature of chronic pancreatitis. So sometimes there is confusion, okay, and diagnostic difficulty between carcinoma of the pancreas or chronic pancreatitis. Ductal adenocarcinoma infiltrate locally, typically along nerve sheath, and this is called causing pain, and also along lymphatics and into the blood vessels. The metastases to the liver and peritoneum are common, and proliferative lesions in the pancreatic duct can precede invasive ductal carcinoma. So this is the pathological. Other pathological features, sometimes there are cystic tumors of the pancreas. And also these cystic tumors may be either serous or mucinous. You know, we have a lot of cystic tumors in the body. Cystic cyst adenoma from its name, it's benign, serous, يعني serous, not mucinous. The serous cyst adenoma typically found in older women, and they are large aggregation of multiple small cysts, and they are benign. But mucinous tumors have the potential for malignant transformation. There are thick mucus seen extruding from the ampulla at ERCP, which is a diagnostic feature. Yani once we do ERCP, you know ERCP, endoscopic retrograde cholangiopancreatography. We see a mucus from the ampulla of Vater. This is diagnostic of mucinous tumor, and definitely it needs histopathological confirmation. Mucinous tumors can be confused with pseudocyst. We should do differential diagnosis with pseudocyst, which is a complication of pancreatitis. And occasionally lymphoepithelial cyst also, lymphangioma, dermoid cyst, intestinal duplication cyst. So these are the differential diagnoses of mucinous cystic adenoma. Solid pseudopapillary tumor is a rare, slowly progressive but malignant tumors seen in women of childbearing age and manifests as a large, partly solid and partly cystic tumors. The tumors arising from the ampulla of Vater or from the distal common bile duct can present as a mass in the head of the pancreas. Adenomas of the ampulla of Vater are diagnosed at endoscopy as polypoidal submucosal masses covered by a smooth epithelium. Biopsies taken at endoscopy may not always include the malignant focus. So endoscopic surveillance, endoscopic resection, or even surgical transduodenal ampullary excision should be considered. You know, patients with familial adenomatous polyposis can present with multiple duodenal polyps. And malignant transformation in a duodenal polyp is a significant cause of mortality in these patients, mandating endoscopic follow-up and pancreatic duodenectomy in selected patients with high-grade dysplasia within the polyps. Ampullary adenocarcinoma often present early with biliary obstruction. Occasionally, other malignant neoplasms can arise at the ampulla, such as carcinoid tumors and high-grade neuroendocrine carcinoma. So there are a lot of pathological process features and characteristic features of CA of pancreas. You should know it. As a clinical features, as we mentioned, because the tumor is in the head of the pancreas most commonly, this may causing a pressure on the lower area of the common bile duct, and the patient presented with jaundice. Typically, it is painless jaundice. So painless jaundice is an ominous feature because it may be caused by CA pancreas. Not like painful jaundice, or jaundice associated with pain or with biliary colic. This may be due to gallstones or cholangitis, gallstones with biliary cholangitis. So طبعا definitely هو شنو هذا الشيء كله هذا obstructive لو non obstructive jaundice طلاب؟ طلاب شو تقولون هذا obstructive لو non obstructive jaundice؟
obstructive دكتور.
عاشت ايدك بارك الله بك. شو اسمك انت؟ شو اسمك يا بطل؟
زين العابدين.
زين العابدين.
ايه
حياك الله، شلونك؟ زين، اهلا وسهلا بك. عاشت ايدك. It is obstructive type of jaundice. That's why it is associated with pruritus, itching, dark urine, and pale stool with steatorrhea are common accompanies of jaundice. In the absence of jaundice, the patient may present with other symptoms like vague discomfort or just upper abdominal pain or anorexia or weight loss. Upper abdominal symptoms in a recently diagnosed diabetic, especially in one above 50 years of age with no family history of or obesity, should raise suspicion. That's to say, the patient may present with just هذا يمتى بالحقيقة ده يصير؟ هذا this condition when the tumor away of the common bile duct, when the tumor in the head of the pancreas but not causing a pressure on the common bile duct, away of the common bile duct, the patient may present with just upper abdominal pain, anorexia, weight loss. So should be you have high index of suspicion. Also, the patient may present with unexplained attack of pancreatitis. So the patient may present with just pancreatitis. This is very serious. That's why we explain it and we discuss it in the previous lecture that you should know the cause of the pancreatitis. Back pain sometimes is warning. As I mentioned, I told you in the pathology that these tumors have perineural metastasis. So back pain raising the possibility of retroperitoneal infiltration. On this is by history. On examination, we find the patient have jaundice, weight loss, and palpable liver and gallbladder. You know curvature law or curvature sign. Well, this is a previous about 200 years ago, more than 150 years ago. Curvature says that when the common duct is obstructed by a stone, the stage of the gallbladder, which is likely to be chronically inflamed, is rare. Why? Because the presence of gallstones causing recurrent attacks of cholecystitis, and this leading to fibrosis of the gallbladder, also shrinkage of the gallbladder. But if the patient have a neoplasm CA pancreas without gallstones, so there will be distension of the gallbladder. Okay. واضح طلاب الكورفيشر ساين؟ واضحة طلاب؟ واضحة
واضحة
زين؟ عاشت
واضح دكتور واضح.
عاشت ايديكم. Also, so on examination, we can find palpable mass. There may be ascites, as we mentioned. There may be peritoneal, peritoneal metastasis, and supraclavicular lymph node enlargement with a tumor deposited sometimes in the pelvis. Okay. هاي الصورة واضحة طلاب. This picture shows large ampullary adenoma that turned into an adenocarcinoma. This picture, after this patient, we did for him, or they did for him, the patient underwent pancreatic conjunctivotomy. Investigation of the patient. Once the patient presented with jaundice, the patient need a blood test to confirm this is jaundice, total serum bilirubin, liver function test, serum alkaline phosphatase, and other blood tests. Also, the patient need ultrasound scan. To start with ultrasound scan to see if there is any biliary dilatation. Ultrasound is a simple test without not invasive, cheap, highly accurate, give good information. So by ultrasound we can see if there is dilatation of intrahepatic biliary tree or not. If there is dilatation, it means there is distal obstruction. So next step is to do contrast enhanced CT scan. If there is a tumor in the pancreas and if the CT scan give us an information if there is any tumor in the head of the pancreas, and if this tumor can be resectable or not. That's to say, if the tumor associated with ascites and peritoneal settling and invading with liver metastasis, this is unresectable tumor. But if it is localized tumor without liver metastasis, without ascites, it can be resectable. So the presence of hepatic or peritoneal metastasis, lymph node metastasis, distant from the pancreatic head, or encasement of the supramesenteric hepatic or celiac artery by tumor are a clear contraindication to surgical resection because there are no radical cure of this tumor, of the metastasized tumor. Sometimes we can use MRI and MR angiography to prove the information with CT scan. Other investigation other than a blood test and ultrasound and CT scan and MRI, we can use also ERCP, endoscopic retrograde cholangiopancreatography, with biliary stenting if there is likely to be delayed between, ERCP, as we mentioned, it is diagnostic and therapeutic. So if the patient has jaundice and we do ERCP, we can put a stent for decompression and relief of jaundice, the drainage of this pus of the bilirubin of the bile, I mean. So ERCP is very important as a diagnostic and not therapeutic, but palliative treatment if there is obstructive jaundice. It can relieve jaundice and can also provide a brush cytology and biopsy to confirm the diagnosis. So ERCP very important. Definitely we need prothrombin time should be checked and clotting abnormalities, vitamin K may need يعني, and fresh frozen plasma before ERCP. Other investigation, other than these previous investigation we mentioned, we can use endoscopic ultrasound. As I told you, we can put a ultrasound probe in the endoscope, in the gastroscope, gastroduodenoscope, OGD. It may contain a probe for ultrasound. So endoscopic ultrasound is useful if CT scan failed to demonstrate a tumor, and if the tissue diagnosis is required prior to surgery, because we can take FNA, we can do fine needle aspiration if we find a mass. So the investigations of patients with CA pancreas by hematology, a blood test, total serum bilirubin, serum alkaline phosphatase, liver function test, and other blood tests. Number 2, ultrasound, يعني imaginary or imaging اللي هي ultrasound, CT scan with contrast maybe, MRI, okay. Also, we need ERCP as a diagnostic and may put a stent in a jaundice patient to relieve jaundice. And endoscopic ultrasound, this is benefit. We can take a biopsy, fine needle aspiration. So a transduodenal or transgastric fine needle aspiration or true biopsy performed under endoscopic ultrasound guidance. That's to say, OGD, gastroduodenoscope, contain a probe for ultrasound. This is called endoscopic ultrasound. Also, in this gastroscope, not only there is a probe for ultrasound, there is we can do fine needle aspiration, or we can do true cut biopsy. This is very important. This gives information though more than the cytology, brush cytology by ERCP. And the lack of tissue diagnosis should not delay appropriate surgical therapy. In patients judged to have unresectable disease, tissue diagnosis should be obtained prior to starting palliative therapy. Other investigation, diagnostic laparoscopy. Laparoscopy not only to perform operation, but also for diagnosis, because sometimes there are small, very small peritoneal seedling metastasis cannot be seen and visualized by ultrasound or by CT scan. We can see them by in diagnostic laparoscopy. This is performed to avoid unnecessary operation. Why we explore the patient and expose him to major, super major surgery really without indication how the tumor may be unresectable. So diagnostic laparoscopy prior to an attempt at resection can spare a proportion of patients an unnecessary laparotomy by identifying small peritoneal and liver metastasis. It can be combined with laparoscopic ultrasound. Also we have a probe for ultrasound in the laparoscope. So ultrasound shabab, there are external probe for ultrasound, and we have also endoscopic ultrasound, a probe of ultrasound with the gastroscope, and laparoscopic ultrasound. With the laparoscope, there is a probe for ultrasound. Other investigation, we can use a tumor marker like CA19, and also it is not specific for this tumor. Till now, is it clear, طلاب? واضحة هسه الانفستيجيشنز والباثولوجي اوف سي بنكرياس؟
إن شاء الله واضحة دكتور.
بارك الله بك، الله يحفظكم ان شاء الله. Now we come to the management. Really, at the time of presentation, more than 85% of patients with ductal adenocarcinoma are unsuitable for resection. Usually, the disease is advanced, and with advanced metastasis, usually there are peritoneal seedling with advanced metastasis. And this is occur in more than 85% of patients. So there are very small percentage of patients, about just 15%, we can do a removal of the tumor. They can get benefit of surgery. Definitely, you know, the treatment is surgery. If a cystic tumor is encountered, no matter how large, surgical resection should be considered, as it carries a reasonable chance of a cure. We mentioned cystic tumor, if it's serous, it is more benign. But if it's a mucus or a mucinous, there are high potential for malignancy. Tumors of the ampulla of water have a good prognosis and should من يقدر يعرف لي شنو السبب طلاب tumors of ampulla of water يعني have good prognosis؟ تعرفون شنو ممكن يكون السبب الطلاب؟ تعرفون زي تعرف شنو ممكن ليش السبب يكون هذا تيومر good prognosis؟ تسمعوني طلاب؟
دكتور لأن الدايجنوستس ما تصير early.
بالحقيقة البرزنتيشن early هو صحيح. ليش يصير الدايجنوستس؟ كلامي صحيح. شو اسمك تعيني؟ شو اسمك؟
أفنان.
أي كلامي صحيح، بس هو شنو بالحقيقة ليش الدايجنوستس يصير early؟ يصير الدايجنوستس early لأنه البرزنتيشن يصير early، لأن البيشنت يصير هذا يصير يعني جوندس. فمن يجينا جوندس ويجينا انفستيجيشن مو مثل ما هو بيشنت خلينا نقول تيومر in the head of the pancreas away of the common bile duct. So because it is in the a tumor in the ampulla of water مثل ما تفضلتي، يعني هو diagnosis يصير early لأن يصير representation early. The patient will find himself have jaundice or somebody يعني notice that he has jaundice, and so may send for investigation, and we can diagnose the tumor earlier before metastasis to the peritoneal cavity and a liver. Some of the rare tumors and the neuroendocrine lesions should also be resected if at all possible. For those patients who have inoperable disease, we need palliative treatment should be offered. This picture واضحة الصورة طلاب؟ واضحة الصورة؟
نعم دكتور.
This shows carcinoma of the ampulla as seen at endoscopy. يعني this is by endoscopy, by ERCP or by endoscope, gastroendoscope, we find this tumor at the ampulla of water. And this is shown by endoscopic ultrasound. زين هذا endoscopic ultrasound. كم نوع آخر من الالتراساوند احنا عندنا طلاب؟ من يقدر يقول لي هسه انا ذكرتهم؟ This is endoscopic ultrasound، يعني عن طريق الجاستروسكوب there is a probe for ultrasound. أنا ذكرت بعد other two types of ultrasound، من يقدر يقول لي شنو هي؟ طلاب وياي؟
دكتور لابروسكوبيك التراساوند.
عاشت ايدك. منو انت زين؟ منو؟ شو اسمك انت؟
فليح دكتور.
عاشت ايدك فليح، بارك الله بيك، منتبه. اذا اكو عندنا لابروسكوبيك التراساوند، والنوع الثالث هو الاكسترنال التراساوند، هذا اللي عندنا الموجود اللي تشوفوه بالمستشفى او بالبرايفت كلينيك. فاذا اكو هذا الاكسترنال التراساوند، اكسترنال بروب، عاشت ايدك فليح، هذا رقم واحد. لكن ايضا اكو اندوسكوبيك التراساوند، يعني the probe of ultrasound in the gastroscope and laparoscopic مثل ما قال فليح laparoscopic ultrasound. So in surgical resection, the standard resection of a tumor of the pancreatic head or the ampulla or is what we called pylorus preserving pancreatico-duodenectomy. That is to say, pancreas, duodenum ectomy, that's to say removal of the pancreas and the duodenum. But we preserve the pylorus of the stomach. Because in the previous operations, what we call it Whipple operation, we remove the pylorus of the stomach. But nowadays, we do what we call it pylorus preserving pancreatic duodenectomy. We remove the tumor of the pancreas with the duodenum, and we keep the pylorus of the stomach still there. Pylorus. This involves removal of the duodenum and the pancreatic head, including the distal part of the bile duct. But total pancreatectomy is warranted only in situations where one is dealing with a multifocal tumors. Sometimes the tumor are multifocal, more than one primary, not only one primary, multifocal. Definitely, those patients need total pancreatectomy. Definitely, also we should remove the whole lymph nodes in the region. The patient's coagulation secretion should be checked preoperatively with adequate hydration because it's obstructive jaundice and the patient may have dehydration. The patient should be aware of the diagnosis and the gravity of the operation and the risk involved. It is high risk operation. Really, the mortality rate are high and the cure rate very little. And 5-year survival very little. It is bad prognosis in general. So the operation has 3 distinct phases. Number 1, exploration and assessment. That's to say, to see if the tumor is resectable or not. Can we remove the whole primary tumor with its involved lymph nodes without a recurrence rate or not? If the patient have ascites, peritoneal metastasis, peritoneal seedling with liver metastasis, this not need surgery. This is beyond surgery. This need just palliative treatment. But in the absence of ascites and liver metastasis and peritoneal invasion, we can do surgery. So, number 1, first step in the operation is exploration and assessment. Number 2, resection. We remove the head of the pancreas with the duodenum and the local lymph node. And number 3, reconstruction. Because we cut and remove the distal end of the common bile duct. So we should do anastomosis between the proximal end of the common bile duct with a raw loop of duodenum and perform other anastomosis. So there are 3 steps of operation: exploration and assessment, resection, and reconstruction. This picture واضحة يا صورة الطلاب؟
نعم دكتور واضحة.
This picture shows the resection of the head of the pancreas in a pylorus preserving pancreatic duodenectomy. As we mentioned, pylorus preserving يعني we keep the pylorus, not remove the pylorus. We remove only the duodenum and the head of the pancreas, and we keep the pylorus. If the patient needs total pancreatectomy or in the Whipple operation, we can remove the pylorus. But usually, the usual operation for CA pancreas is pylorus preserving. We keep the pylorus and we do pancreatico-duodenectomy. This is the pancreatic head, and this is the duodenum. طبعا we do resection of it and separation from the portal vein and superior mesenteric artery, and we should remove the localized lymph node. This is first step, which is resection. طبعا هي first step الحقيقة exploration and assessment. This is the second step of the resection. Third step is reconstruction. Reconstruction of pylorus preserving pancreatic duodenectomy. Because we remove the lower end of the common bile duct, so we do anastomosis of the common bile duct with the duodenum. We called it choledochojejnostomy. Coli, it means bile. Doco, it means duct. Jejunal, it means jejunum. Ostomy, it means opening. So we do anastomosis between the proximal end of the common bile duct with the raw Y of jejunum. Coli, doco, jejunostomy. Coli mean bile, doco mean duct. So coli doco, it means bile duct. Jejunostomy, it means anastomosis between the bile duct with the jejunum. This phase anastomosis. Number two, because we remove the head of the pancreas, so the distal end of the pancreas and the pancreatic duct, we do anastomosis between the pancreatic duct with the jejunum. We call it pancreatico-jejunostomy. This is the second anastomosis. The third anastomosis is between the jejunum and the duodenum or the stomach. يعني between the jejunum يعني with the pylorus خلينا نقول. So there are three anastomosis sites. That's why it is super major operation, carry high risk of operation, high mortality rate really. With a lot of complications, there may be leak of any of these anastomosis, especially the patient may have comorbidities, the patient may have diabetes, they may have ischemic heart disease, hypertension, or other comorbidities. With the jaundice, يعني jaundice itself and the presence of a tumor itself, it is carries a lot of يعني morbidities and risk factor. So the operation and treatment of CA pancreas, it is surgical. A treatment of يعني or the tumor of the ampulla of water is have a good prognosis because diagnosed early, because the presentation early, the patient may present with jaundice. A treatment is 3 steps, surgical operation 3 steps. Number one, by assessment, exploration and assessment to see if it is resectable or not. Number two, we do resection. طبعا previously by good anastomosis يعني good investigation by ultrasound, blood test, CT scan, MRI, endoscopic ultrasound, laparoscopic ultrasound, and ERCP with biopsy or by certain set. So after proper investigation and especially CT scan can give a clue if this tumor is resectable or not. If we decide it is resectable, so and explore the patient, we remove the head of the pancreas and the duodenum. We want keep the pylorus. We call it pylorus preserving pancreaticoduodenectomy and do anastomosis between 3 sites of anastomosis. Number one, between the common bile duct, proximal end of the because we remove the lower end of the common bile duct. You know, the lower end of the common bile duct inserted into the second part of the duodenum. So we remove the lower end of the common bile duct and we do an anastomosis between the proximal end of the common bile duct with the duodenum. We call it choledochogenoscopy. And we anastomosis of pancreatic duct and pancreas with the duodenum. We call it pancreatic chogenoscopy. And we suturing the pylorus and the duodenum to the duodenum. واضحة العملية طلاب؟ واضحة العملية والانستوموسيس؟ واضحة طلاب؟
نعم دكتور إن شاء الله.
أشكرك. Now we adjuvant therapy. Sometimes if the patient have advanced tumor or have malignant يعني peritoneal setting, ascites, or may have يعني liver metastasis and beyond surgery, the patient may need adjuvant therapy. And as we told you that 5-year survival following resection of a pancreatic adenocarcinoma range from 7 to 25%, around 10% for most centers. So they have very bad prognosis. We told you previously at the beginning of the lecture that 85% there were advanced tumor. 85%. Because sometimes if the tumor in the head of the pancreas but not near the common bile duct, the patient may have just upper abdominal pain. anorexia, nausea, or weight loss. So upper abdominal symptoms in a patient over 50 years, very serious. We should exclude CA pancreas. طبعا CA pancreas by CT scan, not ultrasound, because CT scan shows the retroperitoneum very well. Ultrasound is difficult to find it. So after surgery, following surgery, the 5-year survival very low. This is not like other tumors. For example, CA of the breast, we have 25-year survival. Very high cure rate, even the cure rate in the CA of the breast. Also, CA colon have very good prognosis. We have 10-year survival, and بالحقيقة, I have more than 20 years and 25 years old survival after resection of the colonic tumor. So there are tumors have good prognosis like CA breast or CA colon, but tumor of the pancreas have very bad prognosis. And the 5-year survival around 10% in most centers, range from 7 to 25 years, 7 to 25%. The median survival was just 11 to 20 months, just 1 year. After diagnosis, the patient may not be lived more than 1 year, most of the patients. Considering that at best 50% of patients had resectable disease to begin with. This means only 2 or 3 out of 100 patients with the disease could expect to survive to 5 years. So it is bad prognosis. That's why we before doing this super major surgery of resection of head of the pancreas and duodenum with a 3-site anastomosis between the common bile duct and duodenum, and between the pancreatic duct with the duodenum, and between the pylorus or stomach with the duodenum. Before doing this major operation, we should do exploration and assessment to find can the patient get benefit of it or not. If there is peritoneal metastasis, ascites, liver metastasis, there is no need for this surgery. These are contraindications for surgery. And even if we do surgery and do this section with these three sides of anastomosis, choledochogenostomy, pancreatic chogenostomy, and gastrochogenostomy, this carries bad prognosis. A lot of complications, maybe leak, maybe infection, maybe a lot of serious complications. And in general, the patient not be survived more than 1 year. That's why preventive measures like stop smoking, stop alcohol, treatment خلينا نقول patients with familial adenomatous polyposis, for example, they may need follow-up by ARCB, and if there is any suspicion of polyps, we should remove it. I mean, preventive measures are more important than therapeutic. So recurrence could and it show up even beyond the 5 year of cutoff. This is approach to biliary and duodenal stenting. Sometimes if the tumor is advanced and واضحة هاي صورة اللاب، واضحة هاي الصورة عيني.
اي نعم دكتور واضحة.
If the tumor is advanced, if there is advanced tumor with obstructive jaundice and the patient beyond surgery, we cannot be surgery. In this condition, we can do just palliation. And this palliation by stenting of the jaundice. If we cannot remove the tumor, we can do a stenting of the tumor. Stenting of the common bile duct, we put a stent to relieve jaundice. So biliary and endoscopic retrograde cholangiopancreatography, ARCB, I mean, and put a stent by ARCB. This is an endoscope, ARCB, pass to the duodenum, and from the second part of the duodenum, ampulla of water, we put a stent and to bypass the tumor. Okay, and this also show percutaneous transhepatic cholangiography followed by cannulation of the biliary system and percutaneous placement of a biliary stenting. يعني طلاب احنا مو خلينا له ستنت من الاي ار سي بي، يعني باي اي ار سي بي we put a stent in the common bile duct. ايضا بنفس الوقت دا تشوفوا هذا الخط الاحمر، دا تشوفوا هذا الستنت الاحمر طالع من الليفر طلاب، دا تشوفوا هذا الخط الاحمر طلاب.
نعم دكتور.
دكتور واضح.
هذا percutaneous through the skin، هذا percutaneous transhepatic cholangiography followed by cannulation of the biliary system and percutaneous placement of a biliary stent. And also this is the other picture, this approach to the biliary and transduodenal stenting, endoscopic placement of a duodenal stent. Sometimes طلاب the tumor not only causing obstruction of the lower end of common bile duct and obstructive jaundice. Sometimes the tumor is large, causing obstruction of the duodenum itself. So CA of the pancreas may causing obstruction of the duodenum. And so بالذي بيجي ايش ممكن يجيني؟ ايش تتوقعون اذا اكو عندي obstruction بالدودينام؟ شنو الكلينيكال سيمبتومز اللي يجيني بها البيشنت؟ من يقدر يعرف؟ طلاب من يقدر يعرف؟ شلون يجيني بيشنت اذا عنده obstruction بالدودينام؟
بروجكتايل فوميتنج.
هو مو بروجكتايل، انت عوفك بس فومتنج عشان تديكم يجيني فومتنج، بارك الله بك، يجيني فومتنج يعني لان هذا فومتنج لان اكو obstruction tumor of the pancreas causing obstruction of the عشان تديكم وانا اشكركم. فهنا نبي حاله هذا يراد له ايضا الديودينال ستنت، مثل ما طلاب اكيد انتم اخذتوا بالسي اوف lower end of esophagus if it is advanced tumor and cannot be removed also we put a stent. تمام، مو اخذتوها يشرحوا لكم اياها الاساتذه مو صحيح؟ اذا بيشت عنده dysphagia with advanced tumor and restriction بالlower end of the esophagus we can put a stent. تمام لا طلاب؟
بالضبط.
عاشت ايديكم. فاحيانا ايضا اذا هو obstruction of the duodenum قد يحتاج الى stent، وهي هاي بالحقيقه palliative treatment. So palliation of pancreatic cancer number one also يعني to relieve jaundice and treat biliary sepsis, because as you know because it is obstructive jaundice and there is a cysts there may be يعني infection, cysts with infection, so we need either surgical bypass, biliary bypass, and it's also the proximal end of common bile duct with the jejunum, choledochogynostomy, or put a stent through ERCP, or we put it through percutaneous transhepatic cholangiography يسموها، كنا قبل هوايه يعني نستخدمها بالثمانينات percutaneous يسموه شيبا نيدل، كانيولا كبيره ندخلها من الابدومينال وول through the skin للليفر، ومثل هاي كانيولا نسحب الى ان يجينا بايل، ولانه هو البيشنت عنده obstructive jaundice فراح يكون dilated البلياري 3، فندخل بالبلياري 3 ونسحب بايل وبعدين نخلي ستنت نوسعها للتراكت وندخل ستنت. The other palliative treatment of pancreatic cancer is improve gastric emptying, because we said this tumor at the head of the pancreas causing obstruction to the second part of the duodenum and the patient may be presented with vomiting. So either we do surgical gastroenterostomy, or we put a stent, a duodenal stent. Other palliative treatment are pain relief. The patient, as we mentioned, if it is retroperitoneal tumor or perineural metastasis, it causing severe pain. So they need يعني either analgesia or celiac plexus block. celiac plexus block to يعني to relieve pain خطية هذول المرضى، أو thoracic يعني splenectomy. Symptoms relief and quality of life. You need to be encouraged in normal activity, enzyme replacement, because the patient have steatorrhea, treatment of diabetes, and sometimes the patient may need chemotherapy. Is it clear طلاب؟ هاي هسه المحاضرة عيني عندكم